Good morning, brothers and sisters. The word says you have to be ready at all times. I almost said no, Pastor, but I said be obedient. I just want to give our Lord and Savior Jesus Christ the highest praise. And I must say thank God for the worship team. I said I'm not going to cry, but I broke into tears. The worship was so moving and really reminded me of our gracious God and how privileged we are and how blessed we are to be known by Him and to be able to worship Him. So I am really grateful and thankful for Pastor and Jenny. We have met them and come to know them and love them too. We really love them. And it's a privilege, and I thank God for the opportunity. Thank you.
Good morning, everyone. That's my wife. She can usually cover most things for me. It's a great and special privilege to be here today with you and to share this service. As Cassian said, I totally enjoyed the worship, and we congratulate the worship team for all their efforts. We thank God for being here today. Pastor has said a lot of the introduction. But if I just add a little bit to it, we've been living in London for almost 15 years. At the time we returned in August of 2009, and we were visiting, looking for a place to fellowship really, and came in here on the Sunday of the first weekend in September. So we sat at the back. I had not noticed when Pastor came in at the time, but I was sitting next to a gentleman there in the booth with the kids, and I said to him, I asked him, what is the name of the pastor of this church? Why I asked him, just asked at the time. And he said his name is Erland Banfield. Now, that same evening when we left the service, went home, I got a call from the hospital that there was someone I needed to see. It was probably about 6, 7, so it was a little bit dusky already. I got there, and I got the folder, and I looked at the name, and straight away the name came back to me. We believe now this is, was not a chance meeting, and God was obviously doing something which he knew, and he had us come here the week before. Now, Pastor was in hospital. We came back the week after. My wife said to me in the service, something must be seriously wrong with the pastor, the way they are praying for him. I hadn't told her that I had seen Pastor and was scheduling to operate on him the following week. I didn't want her to worry because, she's usually involved in whatever I'm doing, so I did not want her to feel under stress. I was taking the stress myself. Praise God. And then it happened from there. I must say it's a privilege and a pleasure to really meet Pastor and his dear wife, Jenny. They have become our good friends. We love them dearly, and we thank God for the opportunity to share in what he has been doing in their life. I remember Pastor saying to me, he was telling me about all the work he was doing in India and all of that. And, I just thank God for what he has done, what he is doing, what he will continue to do. So this morning we're going to service with a difference. I'm not going to preach, I promise you. But we're going to share a little bit about heart conditions and heart diseases. Because I think this is very important. It's relevant. I think I just did. Yes, you can have your seat. I'm used to standing for hours, so sorry, I thought you were like me there for a while. Okay, so this is just an illustration of the heart where it sits in the chest cavity. It's really in the middle of the chest cavity. It's about the size of your fist in a person with a fit heart. And on both sides, you've got the lungs on both sides, and there is a muscle here called the diaphragm which separates the chest from the abdominal cavity. I will just tell you a little bit more about myself so you know who I am. Most people don't understand the Mr. So I use doctor as well. Pastor obviously is very knowledgeable and he appreciates it, but sometimes it confuses people. But the correct term, yes, is Mr. Okay, so these are the two main areas I work out of. West Shore Medical Center, Doctors in Charlotte Street, and we do open heart surgery every Friday at the Port of Spain General Hospital. I'm a consultant and specialist in conditions, all conditions dealing with the heart and lung. And the first local doctor to perform open heart surgery here with a team independently. Okay, as I said before, we lived in England for almost 15 years and I did my specialization there and then returned. I'm a fellow of the Royal College of Surgeons in England and a member of the Cardiac and Thoracic Society of Great Britain and Ireland and a member of the Global Cardiothoracic Network. I'm an associate lecturer at the University of the West Indies. And this is just a photo of a hospital where I worked in London. It's a very popular hospital for those who've been to London. It's called St. Thomas's Hospital. It's just across the Thames opposite the Houses of Parliament. And we did at that hospital approximately 2,000 open heart surgeries every year at that hospital. Okay? It's a big, I mean, you just see a small bit of it there, but it's really a big complex. In there, there's a cinema, there's a bank, there are 2 restaurants and a coffee shop, and clothing stores, etc. So it is something we are aiming towards here in Trinidad and Tobago. Some of the things I get involved with, cardiac risk assessment, which is very important, and we will talk about that. All open heart surgery, surgery of the chest and lung. See patients in chest pain clinics who've got symptoms requiring investigations. Do anticoagulation clinics as well for patients who are on warfarin requiring those things in general medical services. This is a photo here when our team did one of the first operation with the totally local team at Port of Spain. This is Dr. Henry here, who most people know, former Minister of Health, and this is a patient we operated on who kindly consented to that photograph. Okay, so this morning we're talking about health and we're focusing on heart conditions, but the World Health Organization definition of health really extends a bit further, and health is a state of complete, as you can see, physical, mental, and social well-being, and not merely the absence of disease or infirmity. So there's a lot that goes into health. It's a holistic approach, and while we focus on our own special areas, one has to bear this definition in mind. Now, the Bible is very clear. God wants us to walk in health. But sometimes to walk in health, we need to apply certain wisdom keys. All right? And some of what we'll be sharing this morning may not just be for ourselves, but for other people we know, people whom we interact with. We can share some of those wisdom keys with them. Okay, so estimated life expectancy for different countries. And if you can see there, compared to Barbados, Cuba, and the United States, Trinidad and Tobago is down the bottom. So we have less of a life expectancy compared to some of the other countries. All right? And that is quite striking. These figures are pretty much the same if you go up to 2010. So why is that? I mean, what are we succumbing to? What are some of the things which are affecting us? So the leading causes of death or mortality in Trinidad and Tobago are there. And you can see right at the top, heart disease is the #1. Just to give you a bit of a background, if you think of the United States, figures coming out of the United States tells us that every 30 seconds, someone has a heart attack. Okay? And every minute, someone dies of a heart attack. And this is in the United States where they've got all their technology and advances. So cardiovascular disease is a worldwide problem. Okay, it's not just in Trinidad and Tobago, but it is our #1 area as well, and we need to focus on it. It is also, cardiovascular disease, also the top 2 reasons why people get admitted to hospitals throughout the country. Okay, so if you look at Port of Spain, San Fernando, San Grande, top 2 reasons. Okay? So when we speak of heart disease, there are different types of heart diseases, and we'll be focusing primarily on coronary artery disease this morning, but it's useful for us to have an overview. So this is what the heart looks like. I know there are hearts coming out now for Valentine's. That's not what it is like, okay? This is what it looks like. So this is a very good representation. As I said, it's about the size of your fist. It sits in the middle of the chest cavity with a bit of angulation towards the left. Okay, and the heart functions really as a muscular pump. But like any other muscle, it has to have a blood supply to live. Okay? So on the heart, you've got arteries here, which we call the coronary arteries. Okay? And those provide blood supply to the heart. There are different chambers of the heart, which I'm not going to go into. I don't want to bore you with that. But most of what you see when you look at the front of the heart would be this part here, which is called the right ventricle. Okay? And this tube coming out here, the main one, that's the aorta. And the arteries are attached to that. Okay? So what happens when a person has a heart attack? The blood supply to the heart is cut off. So I will show you in a few other slides what happens to these arteries and how the arteries gets progressively narrowed and eventually blocks off completely. The part of the muscle it supplies, then because there's no blood supply, that part dies. So another type of heart disease, my wife warned me not to show any gory images, so these are, I hope these are okay for you. So if you did a section through the heart like that, and you opened it up anatomically, then there are other important things in the heart. So you've got what we call the valves. So 4 main valves, mitral valve, tricuspid valve, then you have the aortic valve, you've probably heard of it. And if you look at this valve, for instance, you see it's like a parachute. Think of a parachute. So it has the bit at the top, and then you've got the strings or cords which is attached to muscles there. So sometimes you may have, these cords may become torn or ruptured, in which case the valve doesn't function properly and flops up into this part of the heart, okay? Or sometimes the valves may become infected. You get infections on the valves, which destroy the valves. Or as part of an aging process, the valves may develop heavy buildup of calcium, which is called calcification of the valve, and that may prevent it from functioning normally as well. So sometimes you need to actually replace those valves with artificial valves, and these are what some artificial valves look like, okay? There are other things that affect the heart rhythm disorders, irregular heartbeats, etc. Okay? And for that, sometimes you need, some patients may go on to need pacemakers. The heart itself is enclosed in a sac. Okay, so when you do the sternotomy or you make an opening in the chest, you can see a structure beating under there, but you can't actually see the heart until you open the sac around the heart. That sac is called the pericardium. And you can have conditions affecting the pericardium, causing inflammatory conditions, excess fluid around the heart, constricting the heart, making it not function properly. So you can have diseases or conditions affecting the pericardium. And this is just to illustrate. So this is a normal heart here, okay? And this person has had some problems with inflammation around the pericardium. So the size of the heart is increased. There's a buildup of fluid around the heart. Okay, so different types of heart disease. Again, this is a summary slide. Coronary artery disease, valvular heart disease, rhythm disorders, diseases of the pericardium, myocardium, etc. So what are some of the important risk factors we need to be aware of? So top of the list, very important in Trinidad and Tobago, might I add quite quickly, diabetes, okay, very important, high blood pressure, smoking, people who've had previous family history of heart disease. We absolutely must talk about cholesterol, and people who have had history of rheumatic fever. I don't know if you've heard of that in childhood, where sometimes you get pains in the joints and limbs, etc. Sometimes the bug that gives rise to that inflammation can also gravitate towards the heart and affect the heart in different ways. Okay? That usually causes diseases to do with the valves. So there's a big interrelationship between all of these risk factors. And you see I've put them all up there. And if you look at the risk factors singly, so if you've got hypertension on its own, there is a risk of heart disease, but it's on its own, if it's well treated, is probably not too much of a risk, 1.5 times. If you've got cholesterol problems or lipid problems, you see it's 2.3 times. If you've got diabetes or glucose metabolism problems, it's increased. But the problem comes about when all of these factors run together. And for a lot of people we see, they've got multiple of these factors. And so the effect is almost cumulative. And if I start off right in the middle here, bang in the middle there, if you've got uncontrolled blood pressure problems, your cholesterol is uncontrolled, and you're diabetic, you can see you're more than 6 times the risk of developing coronary heart disease. Okay? And you can look at the others and see what happens if you've got high blood pressure and diabetes, 2.8 times, cholesterol problems and diabetes. Okay? So the more of these risk factors you've got, the more critical it is to really address it. Now, these are some figures from our own practice, my own practice, where we did a study of some of the patients coming through, and we found in that group of patients who had established heart disease, over 50% of them were diabetics, 77% of them were hypertensive or had high blood pressure, and by the time they presented, a lot of them had weak hearts, okay, by the time they presented. So that is quite significant. We found again, if you were male, there were twice the number of males in this particular study compared to females. And the male gender is sort of like has a predisposition towards it. I don't know, it may be the ladies look after themselves better, different life stressors, multiple factors. But if you're a man, you've got a higher risk of having this problem, okay? So in terms of the age, no age is really spared. The youngest patient I performed surgery on was 27, okay? And this person had severe valvular problems. The oldest patient down here was 83, okay? But most of the patients were within this sort of 50 to 69 age group. And this holds true. We're seeing many, many more young patients coming forward with these problems. Just a couple of weeks ago, I operated on a man who was 35 years old, very severe heart disease, okay? Very bad heart disease. So if you're diabetic, you need to focus on getting it under control. So I saw, surprisingly, a few weeks ago, there was a reporter on Independence Square interviewing people and asking, so what do you understand about diabetes, etc.? And one person said, diabetes, what is that? Is that some kind of a heart condition? You know, a lot of people, even now, in this time, still are not familiar with some of these terms. Probably if he had said to him his blood sugar was high, he may understand. So what is diabetes? Is a complex condition. It's not really a simple condition. There are lots of metabolic abnormalities and changes which occur in diabetics. But to simplify it, it's really characterized by high blood sugar levels, okay, uncontrolled. There is a gland in the body called the pancreas, I'll show that to you, which produces insulin. And after a person has a meal, that gland secretes insulin, and the insulin that is secreted reduces the blood sugar level, okay? So in patients who are diabetics, there may be issues with either the production of the insulin, so either there is not much insulin being secreted, or the insulin is being produced but is not functioning properly, or there may be a combination of it, okay? And if you've got persistent or chronic elevated blood sugar over a long time, this can result not only in heart complications, but in complications at many other target organs, as we will see, okay? So there is a significant risk for cardiovascular disease if you're diabetic. So this is that gland we are talking about. It's in the abdomen, in a loop of bowel just close to the liver and the stomach, and that's the pancreas. It produces insulin. Now, diabetes is not a thing which is unique to Trinidad and Tobago. As you can see there, it's a worldwide problem. So wherever in the world you find it, wherever in the world you go, there are people who are diabetics. The question is, how are we controlling it and what strategies we've got in place for it? Okay, how are we gearing up our own health system to deal with these challenges? So there are different types of diabetes. You hear terminologies, type 1, type 2, etc. Type 2 is the one we tend to see more in adults, okay, or so-called adult onset. Type 1, these patients are usually younger. In the old days, it used to be called juvenile diabetes, but it's not only juvenile, but most patients below the age of, say, 35 or 40 may come into that category, and there are different genetic associations with it. So people with family history of diabetes, people who've got other, what you call autoimmune conditions may predispose them to these things, all right? So different types, and some ladies are aware for the first time they may be diabetic or potentially diabetic when they become pregnant. Because during the pregnancy, because they're monitored more closely, you're able to recognize for the first time that their blood sugar levels are higher. They may be passing lots of glucose in their urine, etc. But of those people who are picked up in pregnancy, 40 to 60% of them will go on to develop frank diabetes within 5 to 10 years. So just briefly, what are some of the symptoms? What do people complain of? Passing lots of urine, thirsty all the time, always feeling hungry, losing weight when they're not trying to, so unexplained weight loss, tired, fatigue, increased susceptibility to different types of infections, etc. Okay? So risk factors, what are some of the risk factors? So older age, adult onset, maturity onset. People who are overweight, you find if someone is a little bit overweight and their blood sugar levels are higher, if they're able to lose some weight and do a bit more exercise, you find that in itself might be very important in terms of controlling their levels, bringing their levels down without medication. And some of those people may actually have a better control and not require any medication at all. I'm not saying that that would apply to everybody, but if someone is overweight, you should focus on getting them to try and lose a little bit of weight as part of their management, okay? People who are hypertensive, if you're hypertensive, there's a higher risk of having becoming diabetic as well, okay? If your cholesterol levels are high, because what it is with these really is you get buildup of atheroma or plaque or cholesterol in all of the organs, and therefore the organs don't function as well. So if you've got these factors, then it may also affect your pancreas as well, okay? Family history, certain ethnic group, different races. We know that Asians, East Indian, people from the East Indian background are more susceptible to diabetes, okay? And we spoke about gestational diabetes. So if you're diabetic, you're at high risk for having cardiovascular disease. And if you look at people who are diabetics on its own, 68% of them may have heart complications or a stroke. All right, some of these things may be a lot for you to take in, but it's important, and you know, the idea is not to remember all the facts, but to to place the emphasis where the importance is. So, you know, if you've got diabetes, you need to look after it properly. It's not to scare you or anything, but just to be factual, all right? And apart from heart disease, diabetics are prone to other problems, so they develop foot problems. They are at risk of going into renal failure, kidney problems. They are at a higher risk of developing eye problems and subsequently may go on to develop blindness. And this is really just a summary slide to show you that there are different parts of the body that can be affected, okay? So high blood pressure, if you're hypertensive, how does that affect you? So what is high blood pressure? So it's a loss of elasticity or hardening of the arteries, usually something you see as you get older. So if you live to 100, you know, there's a good chance you will have some loss of elasticity and hardening of the arteries. The important thing is to keep it under control. So how do I tell my blood pressure is high? Most people don't know unless it's tested. So you need to have it checked, all right? High blood pressure is referred to in many articles as the silent killer, because the first time someone sometimes realizes they've got high blood pressure is when they collapse with a stroke. Okay? So unless you check it, you don't know. Common question, what level of blood pressure is appropriate for me? Well, blood pressure varies with your age, so depending on your age, your blood pressure may be different. And as you get a bit older, the blood pressure tends to go up with age. We know that. Okay? So what you would accept in a young person, you may not accept in an older person or vice versa. Okay? Because the blood pressure is related to hardening of the arteries, long ago it used to be felt that you needed to have a high pressure to go through those hardened arteries. So blood pressure was referred to then as essential. So that's where the term essential hypertension came from. Okay, but we now know it's not really essential. You need to keep it under control, all right? And certain people who have got other risk factors, so you may have high blood pressure, but if you're diabetic or if you've got kidney disease, then the level at which your blood pressure should be maintained in most instances is required to be much lower. Okay, so if you accept 150 in an individual who has no other risk factors, if you have someone who has kidney problems, etc., you may want to accept 120. So these are decisions you really need to have with your doctor as to what is appropriate for you, okay? If your blood pressure is high, it is high, okay? And British Heart Foundation, you know, they used a figure some time ago where they said if it's more than 140 over 90, they're different numbers mean different things, and you've got the number at the top and the number at the bottom, and they connote different things, okay? But usually if the number at the bottom is more than 90, then you need to have that looked at, come to some decision and strategy as you move forward. So complications, so if you've got uncontrolled high blood pressure, can lead to kidney failure. And some patients may need dialysis. So this is a lady who's having her dialysis, there you can see, due to kidney failure. Strokes, very important, uncontrolled high blood pressure. And high blood pressure, what does high blood pressure do to the heart? Well, the way I look at it is, when you've got high blood pressure, it's like the heart is in the gym all the time. So the heart is having to overwork. So what happens is the heart undergoes what we call hypertrophy. So this is a normal heart, and if you cut a window in the heart to see what the chambers or the cavity of the inside of the heart looks like, you can see what the size of this cavity is. Now this person who is hypertensive, uncontrolled, what happens is the muscle itself hypertrophies, thickens, the muscle becomes very thick. And as the muscle becomes very thick, it reduces the size of the cavity. So there's less space for blood to flow into the heart, and I'll show that to you. So if you did a cross-section of this heart at post-mortem, for instance, so this is the kind of cavity you're looking at, which is tiny, to allow blood to collect and then to be pumped out to supply the whole of your body, okay? So high blood pressure, uncontrolled on the heart, is not good for the heart. It can also cause eye problems, okay? And may lead to blindness if not picked up and treated early. Okay, and now we move on to cholesterol. So cholesterol is something everybody needs to have a handle on. We talk about it a lot. The important thing to say here is that cholesterol is not all bad. It's important for carrying out a lot of the functions in the body to do with cell wall and metabolism, etc. Okay, and it is actually produced in the body. It's actually produced in the liver. All right? But a lot of the cholesterol we are exposed to is what we take in with our diets. Okay, so a lot of the things we eat. So if we are producing a certain amount and we are taking in a certain amount, unless we are able to clear it effectively, then it builds up. Okay? And the problem is when it builds up, when it overwhelms the system, that's where you start getting cholesterol-related complications or problems. All right? So as we said, is necessary in cells, and the problem is when there's excess. There are some people who have got genetic predisposition to how they handle cholesterol. And there are some people who produce excess levels of cholesterol, so-called familial hypercholesterolemia. They produce high levels above normal, okay? Or there are some who they're not effective, their body is not effective in terms of dealing with the amount of cholesterol they've got. So those could be genetic predispositions. Right? There aren't usually many warning signs about cholesterol, okay? So how do you know what your cholesterol levels are? You need to have a formal sort of risk assessment with your doctor, and that may involve doing blood tests, blood investigations to see what your levels are. Okay, especially if you've had a family history of heart disease or someone who has had problems in the past, and we spoke about genetics. So if your cholesterol levels are too high or uncontrolled, these are some of the terrible things that can happen to a person. Okay? You can develop some of these things. Right? So what is the optimum level, or what level should we not exceed? So there are different types of cholesterol. You hear about good cholesterol and bad cholesterol. And overall, your cholesterol should not really be above 200. That's your total amount of cholesterol. But if you break it down further into good cholesterol and bad cholesterol, the bad cholesterol, which is called the LDL cholesterol here, low density lipoproteins, okay, that number should not be more than 100 for optimum risk reduction strategy, okay? And if it's higher than that, you want to decide, well, how can I get it down? Sometimes it may involve taking medicines to help you get it down. So that's the bad cholesterol. So the good cholesterol now, HDL, the high density lipoproteins, if your number there is 60 milligrams or above, that has been shown to actually be protective against coronary artery disease. All right? You want to be within, at least within this range. The higher the number, the better. And when you get to 60 and above, you're on good grounds, okay? You don't want to be less than 40. Now, I did my wife's cholesterol during the week. She was my subject. And I was really impressed. Her cholesterol was better than mine. And I was saying to her, well, I need to eat everything you eat. Of course, she's not there in the operating theater and things like that, so we do it differently. But at least we know where we are, and I think every adult really should come to the point where they have an understanding and appreciation of what their numbers are, okay? That's a step in the right direction. Sometimes, if your cholesterol are high, I don't know if you have ever seen anybody, but sometimes you may see people with these, they're called xanthelasmas. They're like fatty deposits around the eyelids. Okay, you can see that yellow sort of streak around that. Sometimes you can see other people with deposits on their elbows like this. Okay, or this is really bad on their digits. Okay, but for the majority of people, you will not see those things. All right. And then depending on skin complexion, etc., you're not sure if what you're seeing over that person's eye is. So you've got to do the investigations. So Coronary artery disease, we spoke about, this is an important type of heart disease. And basically what happens here, you start off having a normal artery like this. And as your cholesterol level gets high, you get a buildup of cholesterol and what we call plaque depositing with other elements in the blood cells. And over time, the lumen or the diameter or the area of that artery becomes progressively narrowed, okay? When the narrowing is above a critical level, people develop symptoms. But that narrowing has to be at least about 50% or more before you develop symptoms, okay? Now, look at this lovely smooth lumen here. So you can imagine blood is flowing through there very easily. As you get a reduction in the size of the lumen, the blood is flowing here, but it's flowing, the flow is described as more turbulences. You know, it's abutting on the various walls and the slowing down of the flow, etc. Now, people can still live at this level okay, depending on what they do. So if you're a person who is, you have a sort of a sedentary lifestyle, you know, you sit at a desk most of the day, you don't really do too much strenuous things. You might go along like that for a long time very well, and the point you develop symptoms is when it's really critical. But for the person who is a very active person, outdoor, you know, doing lots of things, burning a lot of energy, you find that person may become symptomatic earlier, okay? And at the point where you get persistence of this turbulent flow, you get disruption of the inner layer of the vessels, and then you get other substances being deposited, and that might be what will give you your heart attack, okay? So what are some of the symptoms of these cardiac-related problems? Ischemic heart disease, central chest pains, okay? Sometimes you may get referred pains down the arm. And if the pain is, if you've got the pain is lasting less than 5 minutes, it goes, the classical thing is pain comes on, settles when I'm at rest, okay? Goes away within 5 minutes or so, that's fine. If you have the pain there and the pain is persisting more than 10 minutes, then you need to seek urgent or emergency attention because it may be that you're having a heart attack, all right? So we showed the first site of pain, but pain really can be anywhere above the level of the diaphragm. So anywhere above the umbilicus or belly button, anywhere there, okay? So you can have pains coming up to the neck and jaw, pains going down the arms at the back, or pains in the scapular area, okay? And this is what happens. So the person would have had some furring up of the arteries, and then you get a sudden event where you develop a thrombus in that vessel, and it blocks off, it cuts off the blood supply completely, and that's where you have a heart attack. And when you've developed a heart attack, as I said to you, the reason why it's bad is because that part of the heart muscle, unless it's dealt with straight away, that part of the heart muscle dies. And this is why we say if someone is having pains which is not going away, which is lasting more than about 10 minutes, they should try and get to hospital within an hour. Okay, that's critical, because if you get to hospital within that time, that's the sort of optimum time for treatment. Okay? If you're outside of that time, you should still go. Okay, but you may have to adjust what you do. So the hour, the golden hour, is the important thing you should remember. All right, same thing again. Now we have actually seen inside some of these arteries, and this is not a bad representation at all. It does look pretty horrible in there, pretty bad. Okay, and you can develop similar problems on the heart in other parts of the body as well. So patients who complain of lots of leg cramps and pains in their legs on walking, etc., may be having symptoms of what you call peripheral vascular disease, or PAD, peripheral arterial disease, as the Americans call it. Okay, so that you need to look into as well. So what test shall I do? How do I know what to do? Well, it all starts off with a consultation, and you would be speaking with your physician, your doctor, and you would go through your history, what symptoms you're having, how long it's going on for, etc., etc. And then he may take you, once that bit is over, he may take you on to investigations, which usually includes some blood tests, maybe a chest x-ray, an ECG, and further tests depending on what you say to him at the time. Now, it's possible for someone to have an ECG lying on a couch, and the ECG is perfectly normal, and that person can still have a heart attack, all right? Because that is called a resting ECG, so the person is not under strain. What you really want to know is what happens to the heart, or what is the heart doing when the person is exercising or under stress. So hence the reason for the term the stress test. And this is very important. So basically what you do, you get the person to exercise on a treadmill, walk on a treadmill, okay? And what you do is you start off walking at a pace and you increase the pace gradually. The treadmill itself, so it's horizontal now, but you are able to increase the incline of the treadmill. So you start off flat, you increase the incline progressively, and you increase the rate. So the person has to walk faster and faster, up to the point where they achieve the maximum heart rate for their age, and you're measuring their blood pressure during that time as well, and looking at the ECG to see what is happening. So that is an important test, the stress test, okay? And here we've got a man who is doing his stress test. So you see he's hooked up to all these ECG machines, and he's got all these ECG leads here, which is seeing what is happening to his heart, and his blood pressure is being monitored during that time. Sometimes a drop in the blood pressure while you're exercising is significant. That would tell you this person probably has disease of the arteries of his heart. Or if you see abnormalities on the ECG, those may be the important things you would pick up. And these tests are meant to be supervised, so you need to have someone there who is trained and capable of resuscitation, who can do resuscitation if you collapse. It's not uncommon, it's not common, but it's not unheard of for people to collapse while they're having these tests. So it has to be supervised. So if you're going to have one of these tests, you want to know, what's happening, all right? So if the person has a positive stress test, it shows the abnormalities on the ECGs, then you need to look at the arteries to the heart in detail. And the way to do that is by performing an angiogram, okay? So an angiogram is a test where you put a needle up through the femoral artery or through the groin, okay? And you put a tube or a catheter up through the artery into the heart, okay? Then you inject a dye. That dye fills the arteries and outlines the arteries, and it can show you if there are any abnormalities. It's a very straightforward test. I'm seeing some of the facial expressions from here. But it's not bad. It's a very straightforward thing. Very straightforward. Okay, and the complication rate and so on is very low with this kind of thing. And it gives important information which you can then act on, which could save a person's life. So don't be put off by it at all. All right? Okay, so after you've injected the dye, these are some of the pictures you can get. So this is outlining the arteries. Remember the heart I showed you with those vessels on it? And this person, so the vessel looks beautiful down here, nice and clean, beautiful, beautiful, but look at what's happening here. So if you look at the size of the vessel there, and the size of the vessel there, or the size of the vessel there, and the size of the vessel there, you see this is pretty irregular, and it's quite narrowed. Okay? So this person has a significant obstruction or stenosis at this point. Now, at this point, this artery here is the most important artery for the heart. So if this vessel becomes blocked off and this person has a heart attack, a lot of patients in this position may not survive. Okay? So, but if you're able to pick this up very early, then you can offer that patient treatment, okay, to either bypass this obstruction with a new blood supply. So if this closes off completely, the person is protected and is unlikely to have a heart attack in the future, or there are other strategies which you can use. You can put stents and balloons and all those things, all right? But the diagnosis is the first important thing. So this is another artery on the heart. The arteries on the left side I showed you on the left, and the right side now. And here again you can see, well, you can see what's happening here. So this artery is not a nice, smooth, regular artery. Say these arteries here. These are smooth, okay? Smooth, but there's a problem there. But look at this artery. It's all irregular, knobbly, okay? All the way along. And then at that point you've got a significant narrowing. So those are the things you want to pick up because you can then treat it, all right? Another test you may need to have is called an echocardiogram. It's like an ultrasound of the heart. So the person, you put a probe on the heart, and that will show you inside the heart and show you the chambers of the heart. It's also possible to to get the person to exercise, walk on a treadmill, and then come and have one of these tests. And what you look at, what you are able to pick up with this device is you are able to pick up differences in the contractility of the heart. So you can see there are areas where the heart is contracting nicely like that. There are some areas where it is a bit irregular. What we call, as doctors, regional wall motion abnormalities. So if there are areas where the walls are not contracting properly, then you can tell, well, this person most likely has a problem with the blood supply to that part of their heart, okay? Right, so treatment. So there, in terms of treatment, there are different things you want to achieve, and there are different goals depending on the individual. So there are two categories of people really. There are those who, they've already got these established conditions, okay? And then there are those who may not have these conditions, but their cholesterol is high, their sugar, their diabetes is out of control. So you have different strategies. So it's a combination of things. So for those who have got established conditions, then you need to firstly protect the heart by giving the heart a better blood supply, okay, which would improve their symptoms. If their symptom is one of chest pains or what we call angina, you want to improve their symptoms, get rid of their symptoms, and by doing that and giving the heart a better blood supply, you're able to prolong their life. So that's the first option. And after you've done that, then you modify all the other risk factors as well. So it's hand in hand. But I understand this is a problem here. Now that I'm here, I've got to think about myself as well. I don't want to be in this category. So in Trinidad and Tobago, people don't like going to doctors. You know, even Pastor said, I wanted to share this with you so that this does never happen to anybody. And I'm like, well, I'm here, you know, I can help with that. Okay? So different strategies. So the first thing you need to do is seek help, all right? So if you've got all those blockages, this is what you call a bypass operation. So this person has, say, a blockage here, and what you want to do is to bring a new blood supply, completely independent blood supply, beyond where that blockage is, okay? So when that blockage closes off completely, the heart is protected by this new blood supply. And that is the objective of doing a bypass operation, to give the heart a more secure blood supply, which would improve or get rid of their symptoms, and by doing that, prolong their life. Over 90% of patients who have this operation, who've got significant narrowings, okay, their symptoms go completely. All right? And they live longer. So that's what you want to achieve, improve their symptoms and prolong their life. This is just a short intraoperative shot with the team. Well, I don't have to tell you, that's me there. And we're doing a heart operation on this patient. So there are other techniques which you can use as well. Angioplasty, you've probably heard of. Insertion of stents. This is also a very useful strategy. But how do you select? That's a decision between you and the clinicians. It is very clear there are some patients who are, or some people who are more suited to one technique than the other, and you have to discuss it. Not everybody is suitable for angioplasty, not everybody is suitable for a bypass operation, not everybody is suitable for stents, things like that. Okay? So it has to be discussed between yourself and your clinician. So how do you assess your risk going forward? So we've done this part, you've had a problem, we've treated it. How are you going to keep things okay? So there are certain people who fall into high-risk groups, and you want to target those ones especially, but you want to do it for everybody as well. So there's a lot we can do to promote better health. So one of the things you want to know where am I on this chart? So you want to know, for every individual, depending on how tall you are, you should be of a certain weight, okay? So you want to ensure that you're falling within that green area. Oh, it's back. Right. So you want to fall within that green area, okay? So that's the optimum. And these are the areas, well, you don't want to put yourself under pressure by being in the red area, okay? And if you're in any of the areas apart from the green area, then you need to try and adopt strategies to move towards the green area, okay? Similar, but without the pictures, all right? So this is called body mass index, that's what it means, BMI, and there is a BMI. BMI really is, as I said, the relationship between your height and your weight, okay? And there are certain lifestyle improvement strategies we can use. So this is a pyramid diet, very important. So you want to focus on the things which are better for you. So down the bottom, exercise, weight control, certain types of food. So you want to stay closer to the bottom and not too much at the top. So white rice, white bread, white pasta, sodas, sweets, red meat. You know, you want to avoid some of the things which we know are not really good for us. Exercise, yep. And like, you know, lots of people are very busy. Lots of people are very busy. But you want to, you know, take a little time to do some exercising, all right? Stop smoking for those who are smoking. There are lots of, even in the church, lots of Christians, you know, become saved, but they still have these things to allow the Lord to work them through. But we know that smoking for some people increases the risk of heart disease up to 10 times. Okay? So you want to stop smoking. And if you are on the higher BMI side, you want to find a good program that would help you to lose weight. Now look at what this guy says. So this is his therapist explaining to him, yeah? All right. For those who need medicines or medical treatment, you want to make sure their treatment is at an optimum. So you want to control their diabetes, control their blood pressure, and if your cholesterol levels are on the wrong side of the normal, you want to address that, okay? Now, this pertains specifically to diabetes, but when you ask people sometimes, in a general way, I can extrapolate it, what about education? Why aren't you focusing on that? They say, well, there are not many educators, not many people telling us, sharing this information with us, what to do. Some of them are very busy. Employers, okay? Cultural beliefs. There's some people who feel that, you know, you have to be of a certain size and certain proportion, you know, to know that you're having a healthy lifestyle. So, yes, you look very healthy. Like my son, my last son, he was, how was he? I said 9 pounds, 4 ounces. He was healthy. The other one was 6 pounds. Okay, so transportation problems, lots of challenges, but we need to do our best to make it work, make it a reality. Education programs, if there aren't much material available from our own ministry, the internet will give you lots of information. Okay, there are lots of websites you can get information from. And they're not just information there for the patients or the clients or whatever. There's information there for healthcare professionals as well. All right? Websites. And summarizing again, diet, exercise, smoking cessation, stress reduction, weight control, lifestyle changes. And I'm just going to conclude by saying high cholesterol, diabetes, hypertension are major risk factors for heart disease. Knowing your risk is really the first step, okay? So we have to be proactive. That's the term my wife likes using, proactive, okay? You want to have a discussion with your physician because early treatment and lifestyle changes may make a difference, may actually save your life. It really starts with the individual. Thank you for your attention. Yes, I'll be happy to take a few questions if anyone has some burning questions. Those I can't answer, I'll direct to my wife.
In a situation where a person might have had to do an angiogram and an angioplasty, I was wondering if they need to continue to have their body examined to make sure that subsequent to that procedure, they are on the right track in terms of their diet and all of that. Can they do the angiogram perhaps more often? And how often can it be done safely?
That's a very good question. Yes, I think the point to make is that people who have been through this, whether they've had angioplasties, whether they've had surgery, whatever path they have followed, it is important for them to have follow-up, okay? Now, what the nature of the follow-up may vary depending on the individual. We don't usually recommend, well, I don't personalize it, don't usually recommend routine angiograms for people who have had a procedure if they are asymptomatic, okay? Most of their follow-up would involve controlling their risk, okay? In way of some of the lifestyle changes we've spoken about, and in monitoring their blood parameters to see what's happening with their cholesterol and the other things. So usually the people who get reinvestigated are the ones who they've had a procedure, they've done very well, they've been completely asymptomatic, but now they start developing new symptoms, okay? That's usually the pathway. However, I mean, every case will be a little bit different, and depending on what you discuss with your doctor beforehand, if there was something he was particularly concerned about, and he said, well, you know, you've got some furring up of this vessel. I don't think it needs any treatment now, but let's see what happens to it in 2 years' time. That may be a different indication, okay? So there's no sort of one size fits all, but usually if you have done a complete job the first time around, the only indication in the majority of instances to reinvestigate would be if the person had new symptoms, unless you were aware of something else, which is usually disclosed beforehand.
Good morning. If it is that there's I'm not good with science, so the arteries thing you're showing us, if you start to get like deterioration in your arteries, but like you're young and you reverse your life, could you reverse the process in any way?
So if you're young and what?
Like the arteries already started to deteriorate,
yes.
but you stop and you really give it to God and you stop the KFC and everything and reverse your lifestyle. Is there any way that the arteries could come back to normal, or once it's deteriorated, it's gone?
I like the idea of stopping the KFC. There are studies now which, well, the first thing is you need to go through all the investigations. So you need to know what your cholesterol levels, etc., what your risks are, other risk factors. So the priority really is to be on top of controlling the risk factors, okay? But there are studies showing now that if you have got certain levels of buildup of plaque in your arteries and you're on optimum therapy, etc., depending on what level those therapy are, there might be a possibility of reversing some of those plaques which are there. So that is that is new information coming out which suggests that that may happen in some people. But it's not to say it's something that you say, yes, this will happen to me and I don't need to focus on the other things, all right? Usually the recommendation for reversing plaques would depend on the dosage of the medication the person is taking. So what we find, say you're talking about cholesterol-lowering drugs, for instance, what we find is that the people who are able to tolerate like the maximum or the really high levels of those drugs, sometimes they can see reversal, all right? But not everybody may be able to tolerate that because the drugs, although they are very good drugs, they have effects in other systems as well. And some people complain of, you know, if you started them on sometimes even the lowest dose, they complain of muscle cramps and body aches, etc. So there are lots of things that really want to prevent you from increasing the level of the drug. So it has to be balanced. But yes, there is evidence that there may be some reversal if you're able to tolerate really high levels of some of the drugs.
So, what is the relationship between the pulse and the condition of the heart, and what is a good pulse rate?
Yes. Well, I'll take the second one first. For a normal, fit, exercising person, a pulse rate of about 70 is okay. I mean, look at most textbooks, they will tell you pulse rate of 70 to 73 is okay. Right? For people who have got certain heart conditions, they may have slower pulse rates, okay? Like if you have someone who has a heart rhythm problem, for instance, they may naturally have a slower heart rate. And there are some people who've got other established conditions that you may want specifically to keep the pulse rate below a certain level, okay? So there's no one number that applies to everybody. You have to look at each case individually, okay? But if you were fit and you had a normal heart and you had no heart condition or so on, and your pulse rate was between 70 and 75, I would be more than happy with that. Young patients, young, fit people who exercise a lot tend, as a result of their fitness, to run lower pulse rates. So it's not uncommon to see people with pulse rate in their 60s and even their 50s as a level of their fitness without any symptoms. If the pulse rate becomes too low, most people develop symptoms, and some of them may have symptoms like dizziness, lightheadedness, blackouts, etc. So you don't want it to be too low. And above a certain level, the faster the heart is beating, the more energy it utilizes. Okay, so you don't want the heart to be racing like that. Okay?
I'm just understanding the relation between heart disease and diabetes. In a patient who has been recently diagnosed, she's just 12 years, and I don't know how long she had diabetes for, but recently she has been complaining a lot about chest pains. And I'm sitting here, I'm hearing, and I'm a bit concerned where her heart is concerned with the diabetes, what relationship it would have, what kind of damage it could have done to her heart, not knowing how long she had had diabetes for.
How old did you say she was?
She was 10 when she was diagnosed, and she's now 12.
Yeah, that is really a very young age, okay? And there are people who have diabetes, I'm talking about adults, for like over 20 years, well-controlled, who, as long as it's well-controlled, they do not suffer major adverse effects, but you've got to look at it. For someone of that age, I think the likelihood of her having significant heart problem at that age is significantly low, all right? And I think if she is having chest pains, etc., then one needs to focus on, to look at her holistically, look at other areas to be sure there's nothing else that is causing it, because although she's diabetic, 12 years old, it's unlikely she would develop at that age some of the things we're talking about, unless she has other conditions. You know, we spoke about genetic conditions, family type things, etc. So my overall feeling there is, I don't think you need to worry too much about her, but you need to raise those concerns with her pediatrician, who can then guide you in the right direction, okay? Because there are some children who have abnormal cholesterol metabolism as well, all right?
Thank you, doctor, for the information. My question is, it seems to be that this condition, mitral valve prolapse, is very prevalent. Can you explain to me exactly?
Sorry, it's what?
Mitral valve prolapse seems to be a very prevalent condition. Can you explain that to me?
The condition itself?
Yeah.
Yeah. Okay. Well, it's not very prevalent, okay? Probably, depending on which figures or which data you look at, you may get incidences of up to like about 10%, depending on the individual. But beyond that, I wouldn't say it is very prevalent. When I showed the diagram of the heart, the section through the heart, I pointed out where the mitral valve is, okay? And what a mitral valve prolapse is, usually person may have abnormal tissues that may cause the cords I showed you, the struts holding, like I told you about a parachute and I showed you the strands. Usually in some people, those strands may be elongated, so they may be longer than normal, or sometimes they could be torn. And what happens is when the heart is contracting systole, when the heart pumps to direct all the blood in the right direction, what happens is the mitral valve is meant to close, so the valve shuts. But when you've got someone who has a valve that prolapses, when the valve shuts, both leaflets come together like that, okay? And they're on the same plane. In someone where the valve is prolapsing, what happens usually, because of whatever the abnormality is, one leaflet rises above the other one. And as the leaflet is above the other one, because there is now a gap, you get blood flowing in an abnormal way, okay? In the old days, a lot of patients who had mitral valve prolapse were undiagnosed, okay? And a significant number of those were picked up at post-mortem. But, well, not because it was the results why the person died. It was an incidental finding at post-mortem, okay? Mitral valve prolapse becomes significant when the gap increases and there's a lot of blood flowing in the wrong direction. So then you get what you call, that valve becomes leaky. You get what you call mitral regurgitation. So the jet is going in the wrong way. As the jet goes in the wrong way, over time it can stretch different chambers of the heart and give rise to symptoms. The person may develop rhythm disorders, etc. If someone has mitral valve prolapse, what you need to do is you need to have them in a system where they can be followed up accurately. So they will need to have serial echocardiograms, which I showed there, looking at the degree of the prolapse, looking to see if there are any structural abnormalities, things that can be corrected, assessing how much blood is flowing in the wrong direction and what's happening to the rest of the heart. And then, only after you've done that on serial occasions, then you're able to make a decision, well, this person may need to have A, B, or C done, or that person could continue just being observed. So it's not something that should scare an individual, but the most important thing is that the person has to have good follow-up by an experienced clinician and a good team that can give you the information that is important to you. All right?
Good morning. We're living in the age of emails, and we get emails. I have gotten it. We get emails talking about what to do if you're having a heart attack. There are active things that you can do to stay alive or delay the process of postmortem, of death. And also, sometimes an email will come saying that you might be having a heart attack and not even know that you are. But all emails are not necessarily true. So I just wanted to find out from you, are there symptoms, or what are the symptoms that you could be having a heart attack? And are there things that you can do for yourself or right there that could save your life?
Right. Well, if you remember, I think the biggest one really is the chest pains that you would develop. And if you remember the diagram I showed with the pains, you develop central chest pains, where the pain radiates to down the arms, up the neck, and jaw at the back. So there's the pain, the character of the pain, the duration of the pain. Okay, those are the important things. Sometimes you're not sure whether or not the pain you're having is from a heart attack, but the safest thing to do is to have it checked at the time. Okay, you can't do anything wrong by having it checked, but you can go very wrong by not having it checked. Okay, in terms of what you can do, if the pains are severe and simple things, and the person does not have any allergic response to aspirin or any problems, that bleeding problems, etc., then in transit to your physician or your doctor or emergency room, you can have an aspirin. Okay, it has been shown to be very effective. Giving an aspirin under those circumstances, if there are no contraindications, can do a lot for that person. Now, what aspirin does is, aspirin is an antiplatelet agent, okay? So usually when someone is having a heart attack, you remember I showed you the arteries, and I showed you where you develop a thrombus in the artery, which occlude the artery completely. Aspirin may have the ability, if given early enough, to dissolve that clot which is forming, or if not dissolve it, what happens is, as you develop a clot, you get clot accumulation, so you get more clots accumulating on that. So by reducing the platelet aggregation factor, what you're doing is you're preventing a progression of the thrombus from forming, okay? So an aspirin is a good thing in transit to your doctor.
Hi, good morning, Dr. Rollins. Thank you for your time. What I've been seeing in the media, what happened last week actually, well, during the course of the past week, a young lady, she was up at MOVA. They were suspecting that violence was used against her or something, but what happened is that she had a massive heart attack from the postmortem that was revealed. Well, I have heard that coughing or forcing yourself to cough on the onset of your chest hurting, or you feel a heart attack coming on, maybe you don't have the strength to get an aspirin, or no one is there, and most of the time you're alone. Is that true? Coughing could help the blood to flow through the heart to give you maybe an extension of time to get help?
There's no evidence for that. Having said that, coughing is a reflex. So, you know, most people who would cough would do it spontaneously. Anyway, what I'm aware of is sometimes patients with heart rhythm problems, if their heart becomes, the rate is very slow, they become bradycardic, and that's the term we use. Sometimes that may induce a cough, and that may act, because it's the whole mechanism of coughing involves stimulation of other muscles, etc., and there's increased activity, that may put the heart rate up. But to say that coughing as a form of treatment or something which could be useful, there's no evidence that I'm aware for that, and therefore I'm not in a position to recommend it as a strategy. Okay, I would say, you know, as I emphasized before, if you're having these symptoms, the first thing you want to do is to get yourself to the nearest emergency room or hospital.
Hi, good morning again. I wanted to ask what might be responsible for fluctuations in your blood pressure reading, and if there is a preferred time or way in which to be checking your blood pressure over a particular time frame.
Well, the blood pressure itself can be affected by many factors: activity, temperature, sleep, rest, emotional stress. There's a multiplicity of factors that can affect one's blood pressure, okay? And if one is having fluctuations in the blood pressure, what is usually recommended is for you to monitor that person's blood pressure over a specified period. So what we usually do, we do what you call a 24-hour blood pressure monitoring. So the person has the cuff on there and is taking serial measurements, okay? And then you can then go and analyze that and see, well, what is happening at different times and what is it related to. And then you can, then you can form a treatment strategy as to what to do, all right?
Just a quick one, Dr. Rollins. Could you just give us a sense of the average waiting time for surgery in Trinidad and Tobago? And also, if you could give us a sense of I know it varies depending on the nature of the illness, but the price if one has to go through privately to have it done.
Is that a political question? I'm not sure how to take that one. But suffice it to say, no, I'm not in a position to give you any information regarding the waiting times for surgery. And in terms of costs for surgery, I usually, while I may have some idea, I usually stick to the job at hand, focus on the surgery. But if you would like specific information, I can always refer you to someone where you can get more detailed and accurate information. So I would not want to comment on that. What is a heart murmur? Okay. That's a good question, a very common question. When blood flows through the heart, it usually, as it comes into contact with the different structures in the heart, it gives off a sound, okay? And that sound, when it's audible, when you put the stethoscope on the person's chest and you listen, sometimes you are able to pick up or recognize those sounds. Some of those sounds may be normal, some of those sounds may be abnormal, okay? In children and young adults, a lot of those sounds you may hear may be normal for the age of the person. But abnormal heart sounds, abnormal murmurs, are usually a manifestation of problems to do with heart valves, so usually heart valve abnormalities, okay? So if you are an experienced clinician, a lot of the times when you listen with the stethoscope, you can recognize the murmurs and you can tell what you think it is. But to be sort of evidence-based, although you may already know what you think it is, we still recommend for those patients that they should have an echocardiogram to give proper documentation as to what the abnormalities are.
Mr. Rollins, good morning. I, a month ago, had a mild heart attack. And I was told that I have a heart condition now because I was taking wrong medication for high blood pressure. Is that possible?
Well, anything is possible, but the question is, what medication were you taking? I mean, this sounds like an individual, sort of a case where you need to individualize what you say, and I just want to be a little bit careful here and not go out on a limb and support or discredit what you've been told and say to you that what you probably ought to do is to consult with someone you feel comfortable with, you have that rapport with someone you have the confidence in as well, for them to make some of these decisions and advise you carefully, because it's not uncommon you hear people say things like these, I've been taking the wrong medication, etc. And it just doesn't put you without knowing the details of the case, it doesn't put me on a good footing to make a judgment or a recommendation, and I would rather not,
But that is possible, right? But that is possible. But you wouldn't like to comment on it, but it is possible.
Well, without knowing, I'm not in a position to comment. But I would be, if the medication you were taking were prescribed by, a licensed physician, you know, I would be surprised but also disappointed to think that someone would put you on the wrong medication.
Hi, good morning, Dr. Rollins. I am both hypertensive and diabetic. Occasionally I'll get these shooting pains on my hip, down my left leg, and also some stabbing pains under my left foot. What is this symptomatic of? Can you tell?
Usually in circumstances like those, you have, as a clinician, you've got what you call a differential diagnosis. So that could be symptomatic of, you know, different things. As to what it actually turns out to be may require further investigation. So I don't want to, you know, to give you the impression that it's being caused by A, B, or C without putting you through that, the necessary gamut of investigations, etc. But people who are diabetic, shall I say, if the diabetes is uncontrolled, as I showed from the slides, it's not uncommon that they can develop what we call peripheral neuropathy or peripheral nerve symptoms, which may be manifested in that way, but it's not the only thing that can be, and there are other things I can think about straight away as the potential differentials, which one would need to explore.
Hi, good morning. You said that our body produces good cholesterol and we have bad cholesterol. What can we do in terms of lifestyle to encourage our body to produce good cholesterol?
Yes, I think a lot of what we see in terms of lifestyle without medication producing good cholesterol has to do with exercise. So if the person is fit and is able to exercise and does not have any other risk factors that would prevent them from exercising, then an exercise plan is very good, and you can monitor serially what's happening to those levels.
Good morning. Good morning, Dr. Rollins. Thank you for what you have shared this morning. From what I've heard, I am at a high risk of heart disease because I have all three: diabetes, cholesterol, and hypertension. Now the thing is, I take medication for all. My concern really is the side effects of the medication. And am I at a good candidate for the stress test?
Yes, yes. Well, the first thing to say is that, you know, I understand your situation, but there are lots of, don't feel as though you're out there on your own, because there are lots of people who are facing these challenges, and the fact that, you know, you're asking the question and you're here sharing some of the information really is a step in the right direction, okay? So you are doing what you can, and you need to continue doing what you're doing and seek the advice of people with relevant information. Yes, so you're on all these medications. Side effect is a factor. I mentioned earlier when the other young lady asked me about reversing the disease, I spoke about drugs and dosages of drugs, etc. I think what we're doing here in terms of the decision to commence you on medication is a decision, I'm sure, which would have been clearly thought out, okay? And what you need, the way you need to look at it is in terms of the risk-benefit ratio. So you know the benefit is controlling the blood pressure, controlling the diabetes, controlling the cholesterol. So those are very clear, okay? The risks are what those side effects might be, okay? So they're not a reality, they are a risk, okay? And as long as you have the information to know what those potential risks are, then you can monitor as well. You've got to be sort of like, you know, taking up the challenge yourself as well, and focusing and looking, seeking to see if you are experiencing any of those symptoms. there are quite a lot of different types of medication which people can be placed upon. So if you are experiencing, say, an adverse effect with one particular type of medication, then there are usually others that it could be changed to or adjusted, okay? So the importance really is to control the risk factors, and you can always change the medication along the way if the ones you are taking are giving you symptoms, all right, or adverse effects. With respect to the stress test, there are specific criteria for stress testing, and you know, once you follow those criteria and you stick within the guidelines, and as I pointed out, you're in a facility where you've got people who can look after you, etc., I don't think it would be a problem. And from here, you know, just, you look quite young and very fit to me and so on, so I don't think that you would have a problem doing a stress test.
Good morning, Dr. Rollins, thank you. I am actually the mitral valve patient you would have spoken of earlier, and I have a question based on that. In 94 to 95, I was actually diagnosed with a heart murmur and then subsequently the mitral valve regurgitation. And I went through the series of tests that you spoke about, the EKG, the ECG, and some other stuff. And it showed that it was a very mild condition. I was never medicated, nor am I observed regularly. However, my last test might have been like in 2001, and it was just really for the GP to determine if I'm having problems with the heart or symptoms of anxiety. And I'm wondering, how can I continue to determine what's happening with my heart if these symptoms are similar?
Yes, that's a very good question. Well, what you need, I mean, the most important thing for you to do is to have serial echocardiograms, okay? Because the echocardiogram will tell you what is happening to the heart, the chambers of the heart. It will tell you if the chambers are increasing in size, if they're staying normal. It will also tell you about the function of the valve, and it will tell you about the degree of mitral regurgitation. For people who are asymptomatic, or those who, where the amount of regurgitation is very mild, then follow-up is what is advised. Recommendations for further treatment are only made on, you know, follow-up over time and comparing the investigations over time. So this is not something you should worry about, but it's important for you to have the serial echocardiograms. Probably I should just say one thing there. One of the things we found here with the whole open heart surgery and, you know, and patients with different valvular problems, because we are doing more and more heart surgery here, you found even among some of the doctors who weren't used to having a heart surgery program, there was a degree of reluctance to refer some patients with these problems, okay? And if the patient was okay, they would, you know, they would say, well, you know, let's see you in 6 months, what have you, and they would refer the patients only when the patients develop symptoms. But that is not the best way forward. I can tell you as a specialist in this area, what you want is for these people to be followed up appropriately and for them to be referred early rather than late, because sometimes when you start developing symptoms, that may be at a much advanced stage where you're now at increased risk for complications, etc., and all those things. So if you know you've got a condition, part of the responsibility really is on the individual, you know, to be proactive in their care and to take the responsibility for themselves.
Morning, doctor. I have a question to ask regarding weight. We had some nurses that came around to where we worked, and they checked our cholesterol and our blood sugars. I checked my cholesterol and my blood sugar, and that was good. And then they took my weight, 185. She told me I'm overweight, I need to lose 20 pounds. How correct these charts are regarding weight?
You're not too upset about that, right? The charts, I mean, as everything else, the charts are a guide. What I showed on the chart was not just weight. And you need to understand what chart this person was quoting from and what they were measuring, because as I showed you there, what we are looking at is the body mass index as the factor between the weight and the height. If you take someone who is 6 feet tall, for instance, of course they might be 180 pounds or something. That might be perfect for that person. But if you have someone who is 5'1" and they are 180 pounds, well, then you've got a problem. So you have to see what the person's weight is, but not just the weight, what is the person's height, okay? And then you come up with that ratio, and on that ratio you can decide.
Doctor, we just have a request here. Somebody wishes to remain anonymous, but they asked the question, how reliable is Jameson 369 as a prevention?
Not Jameson 370. I have no idea what Jameson 369 is. I am assuming it is one of these coenzyme Q tablets or one of these things. Yeah, I'm assuming it's one of those because the brand rings a name. What that person needs to understand is what is in Jameson 369, okay? That's the first thing they need to know. So they need to know what are they taking, and they also need to understand for themselves, what do I want to achieve based on what my numbers are and the target I've set myself. So once they can work that bit out, then they'll be able to tell whether Jameson 369 is effective for them.
Good morning, doctor. You hear a lot about high blood pressure affecting the heart. But recently, my blood pressure really dropped very low, and so they had to run me through a gamut of chest tests. Is there fact that low blood pressure can affect your heart? Because it's just as bad, actually.
Again, you need to, when you talk about, well, in this case, low blood pressure, you want to know how low is low. For people who have got certain heart conditions, they may have a low blood pressure without medication because their heart is not generating a higher blood pressure, okay? Generally, if someone is fit and healthy with no heart condition, when you say, most people who say low blood pressure may actually be referring to normal blood pressure, okay? So you have to, probably we can speak on an individual basis afterwards, so you can tell me exactly how low was low and what else was happening, because for someone who has a normal heart, I'm not usually worried when you say my blood pressure was low. I mean, a lot of ladies in pregnancy, for instance, have blood pressures of 90/60, sometimes even marginally lower than that, and they are pretty healthy and asymptomatic, okay? But that happens as a physiological change which occurs during pregnancy, okay? So we need to be a little bit more specific before we can make recommendations.
Doc, good morning. I just wanted to know, I know it's not totally and widely accepted, but what do you think of chelation therapy? And is it something that could help restore normal blood pressure? The elasticity, to be more specific, the elasticity in the arteries.
Doctors sometimes can be a little bit biased, to certain treatment modalities. And it's probably best for me to say that I don't have much experience with chelation therapy. A lot of what we recommend are things which are tried and tested. You have got good research, good background, good evidence base to it, and therefore we are confident that on the basis of what we know, what the data is available, what's available to the public, we make recommendations. chelation therapy would probably come into the other side you call sort of like alternative or non-traditional medicine. I'm aware that some of those things may work. If I give you an example, I've been told by, you know, some people that taking garlic may lower your blood pressure. I've heard that. But the challenge I have with that is how much garlic do you take? How often do you take it? So look, so we've got an expert on garlic there. So that's great. But what I'm saying is the shortcoming of a lot of these things are that you're not able to measure the effectiveness or the, you know, the efficacy, and therefore you can't recommend. So how many doses of chelation therapy do you take? Over what period of time? How do you monitor, you know, to see the benefits, etc.? So I'm not anti to, you know, these sort of non-traditional thing because I don't have a basis in that realm, and I know that some of it may have some benefit, but I'm not in a position to recommend it. And if you ask me personally, I will not recommend chelation therapy for patients or clients I see, just because I don't have a strong evidence-based background in it to say that I know it is doing this. So I'd recommend for you what I know is tried and tested. Okay?
Good morning, Dr. Rollins. I have been diagnosed with high blood pressure. Well, I was put on medication, and the medication had side effects of bad cough. I spoke to the doctor, he changed the medication, and still same bad cough. I decided I was going to stop, and my pressure normalized for a while. The doctor also said that once you start the medication, you have to continue it for life. Is this the truth? And also, what I want to know is if you have high blood pressure, I know exercise and so also helps with that. Could it be reduced, and could you go back to a normal life without medication?
Most people, physicians who treat people with high blood pressure or with degrees of elevation, remember I started off saying that blood pressure is influenced by age, okay? So depending on the age you are, you accept different levels of blood pressure. And personally, me personally, I am usually very careful about starting people on medication, because usually when you make the decision to start someone on medication, you're committing them to lifelong therapy. Because if someone is truly hypertensive or got high blood pressure, and you commit them to a medication, they should really stay on it for life, okay? Because what you are clear in your mind about is that this person, without the medication, their blood pressure is not being well controlled and is likely to have potential deleterious effects for them, some of which we've seen. So you don't want anybody to succumb to kidney failure or heart problems, etc., okay? So it's very important to, you know, to be very careful before you start someone on medication. And usually what that involves is seeing that person on multiple occasions, okay, and measuring their blood pressure over and over and over again, okay, and being convinced that all the other things like exercise and reducing the salt in their diet and drinking less water, whatever the other strategies you recommend for blood pressure control, that none of those are working, okay? So at the point where you start someone on it, you really should be on it over the long term, okay? There are some medicines, you said, which can cause a cough. I'm well aware of that. But there are some which do not cause a cough. And the question is, if you are really, truly at risk of blood pressure, hypertension, high blood pressure, and requires medicines to help you in that direction, then there are other things you can change. I mean, the thing about blood pressure, again, is that depending on when you measure the person's blood pressure, it may look normal, okay? So if the person is very relaxed, you know, and having a good day and something, and you measure the blood pressure, it might be normal. Or if they took a tablet in the morning, for instance, and you measure it in the afternoon, it may be normal. But what you don't know is what it is at the time you're not measuring it, okay? So what is happening the rest of the time? And sometimes that's maybe where you have a problem. So a good thing for you probably to do is to have like a 24-hour period of monitoring where you can monitor it regularly and see the trend throughout the day. And then that may help you.
Thank you, Doctor. Just to remind ourselves that because of time, we can only take a couple more questions, so bear with us. We have somebody on the side waiting to ask a question, but again, we got another anonymous request, and before I give my sister there the mic, it reads like this. My pulse for most of my life reads no more than 44 to 45. I'm not athletic, but do walk a lot. Sometimes I get a squeeze in the central area of my chest, which hurts. It comes and it goes. In the past, I've been told that I have a slight murmur, and I've done most of the tests you have spoken of, with the exception of the stress test. Nothing seems to show up. I do feel disoriented at times. What do you think may be the cause of this, and how can you help?
Okay, that's a very good question. A lot of details there. I think if that person has, from what I'm hearing, if I'm hearing correctly, there are multiple symptoms. Okay, so you've got the bit with the pulse, you've got the tightness in the chest, all of those things. I think that person, although he has had some investigations, I'm saying he, whoever the person is, there may be additional things which they need to look at. Okay? Again, depending on the relationship you have with your doctor might be able to take you through that. But if there are any areas you feel uncomfortable about, then I'd be happy to advise and make recommendations in those directions.
Good day, doctor. My mom is 84 years and she's diabetic. Right? We had her pressure under control. For the past 3 months, she has been coughing. And when we called the physician, he said that she had fluid in her lungs and she had the cold as the virus was going around. He kept giving her medicine like bronchosolvine and cough medicine, but the cold will go for a little while, she'll be coughing, and then it will come back. Since last week, we noticed that during the night, she's been gasping for breath as though, somebody run and they're tired and they're fighting to breathe. We called the doctor on 2 occasions. He said that she was depressed and she need to go to different for children home to get her mind off the depression. 2 occasions he came and he tell us the same thing. We told him that she fighting to breathe at night. He said that that is one of the symptoms of depression, right? And this week, well, every day she keep getting worse and worse, but he keeps saying nothing is wrong with her. We told him to check her heart. He said her heart was good. Nothing was wrong with her heart. And on Wednesday, we took her to the hospital. And the doctor there said that her heart was failing. And as it is now, there's nothing that they could do for her. Is it true?
So this is clearly a very unfortunate situation, and I was about to ask you whether or not the doctor who was looking after her initially, was he a specialist in that area, or was he a specialist overall, and to recommend to you that sounds as though you needed some specialist help. Having said that, she is in the hospital now, and I'm sure she would be investigated within what their capabilities are. But if she gets well enough with the treatment they're giving her to the point that she is able to be discharged from hospital, then she would need follow-up and further investigations from a specialist.
Good morning, doctor. Early in your presentation, you spoke about, when you were talking about diabetes, you spoke about the pancreas releasing insulin to regulate the blood pressure, not blood sugar level, right? And then you said something which I found was very interesting about the insulin not being effective at certain times. Can you please explain why that would happen?
Yes, this is a very complex situation, and I don't really want to, to take it to sort of a medical type forum. But from what we have seen, we know that some patients may develop what you call, the term is insulin resistance. So although they've got the insulin, it's not either there's problems with the insulin getting into the cells, being uptaken by the cells, or being metabolized by the cells, etc. So it's a very complex situation. It's not something that you can explain easily like that. I mean, the first line I had there was that diabetes is a complex metabolic condition. Okay? I think I don't want to get into too much more medical details, but just to say to you, as I have said on the slides there, the problem with diabetes is that some people may not be producing enough insulin, but there are also situations where you've got the insulin being produced, but it's not functioning effectively for different reasons at the cellular level. Or there may be combinations of the two, and leave it at that. I mean, I think the details, the pharmacokinetic details and the metabolic details is far beyond the scope of what we're trying to, to share here. And I don't want to get into that level of detail for the purpose of this discussion, if that's all right.
Okay, we want to say thanks very much to Dr. Rollins.